With gratitude and pride, I introduce Dr. Darcy Krueger.
All right, I've never been accused of being soft-spoken, so can you hear me in the back? All right. Sometimes my content isn't that useful, but you at least hear me say it. The second thing is I want to validate the question that came over here on the side. Is like, what are we doing here? And you've heard allusion to our meeting yesterday, and I know not all of you were there, because it was more, it was appropriately called a roadmap. And we were steering, saying, okay, different people are doing different things. What's our next step and where are we headed? So think of all the talks this morning that you're getting bam, 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 bam. These are the building blocks that we are laying a foundation for the next step. And if it's not clear to you what these foundation blocks are, I can tell you they're all essential. And if we're not doing them, we can't move forward. But if it's not clear to you kind of where we're going or how they fit together in this afternoon where we have all the speakers back together, hit us with that question again, okay? All right. I work with a lot of different people. A lot of different people pay me. But the main one that's relevant here is that I do serve on the Science and Medical Committee for the foundation. All right, you're going to hear me talk a lot about tuberous sclerosis because that's where my journey started in all of this, just like you heard from Dr. Mirza, you know, where it was talking about all megaencephaly conditions, and there's high relevance here. And the value of this is that not all of our building blocks are going to come from Smith-Kingsmore. We need Smith-Kingsmore data and information in your guys' patient journeys, but we're also going to need to build on other people that have already laid the foundation that we don't have to replicate and duplicate and spend the 20 years that I've been working in tuberous sclerosis. We get to start on year 20 of that journey and add our piece to it rather than start it over. And I will tell you, when we talk about rapamycin, tuberous sclerosis did not start the rapamycin journey either. We built on a previous 20 years of experience of using rapamycin in transplant medicine and cancer biology. And so we were able to go very quickly into human trials. And likewise, Smith-Kingsmore is not going to have to replicate all of that work either. This is a molecular pathway. This is very simplified version, and it just shows you that where mTOR is central to a lot of different disorders. And actually, in addition to tuberous sclerosis, there are a variety of genetic conditions that have been described, and we know the genes that are responsible for those, that all have relevance to Smith-Kingsmore. Okay, and so it's relevant to pay attention not only to these small number of papers that say Smith-Kingsmore in them as we try to understand this disorder, but pay attention to what's going on in what we call the gatoropathies, because they also influence what mTOR does, and they have really hard to treat epilepsy, and there's a lot of work going on in that field as well as nutrition and metabolism implications there. There is a very rare genetic condition that involves strata that have patients that have very severe and progressive mental declines early in life and a progressively fatal epilepsy because it can't be controlled. There's segmental overgrowth syndromes and there are drugs also being applied or tested in these conditions as well. So I just want to make that we're part of a larger family. We call these the mTORopathies collectively. And we also know that when we start to get really down into the details, when we look at brain specimens that have been donated or coming from epilepsy surgery cases, we see very much similarities to how the cells look and how they behave. And again, this is also informing us where we should go with Smith-Kingsmore. Now, in particular, we know that there is a very abnormal brain cell that is shared between Smith-Kingsmore and tuberous sclerosis called a balloon cell. Balloon cells are important because they're kind of like a neuron, and neurons do the talking in the brain. They're kind of like astrocytes or glial cells, which do the influencing how the neurons are located and how they find each other. And now we also appreciate increasingly more that they actually tell or talk to the neurons and influence how the neurons talk to each other as well. So the brain structure there, but we see the same abnormalities even down to the cellular level and molecular levels. Now, we do see a variety of abnormalities in the brain. We saw some pictures of those earlier today from Dr. Mirza. And one of the hallmark features of tuberous sclerosis is what we call tubers or focal cortical dysplasias. And we don't see this in every Smith-Kingsmore patient, but there has been descriptions of very similar even findings on MRI. But it isn't the only thing we see in tuberous sclerosis, and it's not the only thing we see in Smith-Kingsmore. And the best series I like to date is this paper that comes from 2018, which really looked at a handful of patients that were in their clinic, and then they just poured through the literature to look for additional cases and try to put, this is what the phenotype of Smith-Kingsmore looks like and how prevalent these things are. What we consider core features are the large head size, okay, which also corresponds to a large brain. Megaencephaly refers to brain. Mega is big. So that's your Latin course for the day. Okay, and we know that kids struggle in their development and their learning, and intellectual disability is a very prominent feature of most patients with this diagnosis. This series, and you saw Dr. Vesterman reference this, previous reports of 74% of seizures. But both his series that he shared today and in our series in Cincinnati Children's that we started with the first Smith-Kingsmore family meeting shows that seizures are probably less prominent, somewhere in that 40 to 50% range. And then that's my topic today. We see other aspects that involve neurodevelopment. Like I said, we see other types of MRI abnormalities that we can describe. And we see how the brain talks to the muscles, which can result in low tone. We see ADHD and impulsivity. We see autism. And we see also the hyperphagia as prominent features as well. But let me just focus on seizures since it's just a quick talk. We see all types of seizures. Most commonly, though, they're going to be focal seizures. And the focal seizures can be with changes in awareness. They can be with retained awareness, or they can generalize into a full-blown seizure. We see all those types there. There have been reports of generalized seizures. If it's anything like tuberous sclerosis, I suspect we're going to find out that they're probably still focal and starting, but they just go so fast in their spread that we don't see the focal part, and so we don't recognize that. Sure. All right. So when we talk about, and these are what the picture shows, so focal seizure means that there is one part of the brain that is starting to fire abnormally. And if it stays in that one place, the brain kind of shields the rest of itself off. It stays focal. It means only that part of the brain is firing abnormally. And so we only see a portion of the nervous system affected. So that can be just an eye twitch. That can be just an altered awareness. It can just be an arm or a leg twitch or something like that. That's what we meant by focal seizures. Generalized means that focal seizure now has spread to involve more areas of the brain. And the classic version of a generalized seizure would be either what we call an absence seizure, which we don't see a lot of true absence epilepsy in Smith-Kingsmore, or a grand mal seizure like you've seen in the movies, okay, where somebody tenses up and then they go to where the whole body is involved at once, okay? So that's the difference. Thank you. All right, and like I said, our estimates are starting to get more refined, and this also represents the genetic era. As we get more and more individuals identified with this condition, we find out that there is more types or phenotypes of the disorder than the patients who got tracked in only because they were having seizures, okay? All right, but even in that, and we've already kind of said this, even if you have seizures, there's a huge variability, not just the seizure type, but when you start having seizures. And we've seen some seizures start very young in life, and we've seen some patients have seizures more as teenagers. We've seen some patients start with seizures, maybe they only have one and they haven't had any more, or they'll go years without any and then they'll come back. We also see that even if they have seizures, they may be different in length. Some seizures may only last seconds. Some seizures for patients may last a minute or two. Some patients may have clusters where they come back to back to back, okay? And like I said, depending on how focal that area of abnormality that firing is often starting the seizure, depends on how intense the seizure is or how much of the body is involved in that seizure. So here's the big question is why? Why all of this variability? And I don't have the answers per se, but we know all of these can be, and probably all of them are, involved in why seizures vary in Smith-Kingsmore. Number one is, other than megaencephaly, we don't have a universal brain pathology. I tell you that we find these features that seem pretty consistent, but how, if somebody has corporal callosal problems, somebody has focal cortical dysplasia, somebody has focal cortical dysplasia in just one area versus multiple areas. Focal cortical dysplasia can be very tiny. Focal cortical dysplasia can involve entire half of the brain. And so there's no aspect of Smith-Kingsmore says everybody's brain is going to look like X. Okay, so that's one reason. The second, we know, and we heard from Dr. Besserman, Dr. Mirza, that not everybody has the same variation in their mTOR gene that has Smith-Kingsmore. And we are appreciating that at least in some of those cases, that variant matters, that it can change on what the profile of Smith-Kingsmore looks like in not just neurobehavior, as we heard this morning, but also epilepsy. Third is, we do know that some of these patients have mosaicism, and I know Dr. Mirza didn't go into intense detail what this is, but the concept is not every part of the brain has the exact same impact, both genetically, molecularly, structurally, and that mosaicism also creates variation clinically. And then one of the things we just have to admit is that we don't understand epilepsy, period, to the extent that we would like to. And no matter what the genetic or structural reason for a person's epilepsy, we know that we haven't solved the riddle because we keep developing new drugs to treat epilepsy, yet our resistant patients continue to still exist. So there is some aspect of epilepsy that we haven't cracked the code yet in general. All right. So I want to just go through, well, what do we do? Okay, so number one is parents ask me, well, how do I know if my child's having seizures? Because especially if a child has autism or autism symptoms, even without a diagnosis of autism, there are things that kids do, like daydream or zone out, that are not seizures, okay? And so here's usually my list that I go through with parents to say, these things, I'm saying, I can't guarantee if they check every box here that it's a seizure, but you and I definitely should be talking about whether we think there's more going on to this or not, okay? Number one is you're looking for something that's always the same, okay? If it's an area of the brain that knows how to start a seizure, and that area of the brain controls certain external functions, we generally should see the same things, okay? Now, seizures can change over time, but within a very short period of time, it's usually the same part of the brain that is acting up, okay? Number one is, the event has some randomness to it in the sense of you can't always predict when it's going to happen, okay? Now, there are some types of seizures that we can predict. Years ago, I had a patient that if he stubbed his toe, he was going to go into a seizure. The most bizarre A equals B scenario that I've ever encountered in my neurology practice. But the way that I explain that is, well, there is a sensory signal that goes from his toe up to his brain and hits one of these faulty circuits every time, okay? So there are some triggering situations, but usually parents can't say, oh, in 10 minutes, my boy's gonna have a seizure, okay? So versus if it's behavioral, it's like, hey, I tried to take this away from my child and boom, they did this thing, okay? That tends to move us away from seizure concerns. Third is, seizures tend to have a very distinct start and they have a distinct end. And the way that I get to this with parents is like, tell me what clued you in that your child was having a seizure or this might be a seizure. If it's more kind of ambiguous and vague, then it gets harder for us to really be sure that it's a seizure. But the classic is 1 minute we were doing this and then boom, I couldn't get their attention. Lights were on, nobody was home. It was one situation and we were in a different situation. And likewise, and then I asked the parents, how did you know it was over? And most parents, if it's a seizure, they can tell me when hey, they're out of it, it's done, okay? Versus, well, it went on for like 20 or 30 minutes and maybe it was over, maybe it wasn't. That gets harder for us to know that it was a seizure, okay? Classically, but not all the time, seizures, the brain, as it shuts off the faulty circuit, it is protecting itself, but it will do so in a very broad way. This is like you have an electrical fire in your house and you don't know which circuit it is, but you know it's one of the circuits that started it, so you just run down to the circuit board and you start just flipping things until it stops, okay? The brain will not turn off any circuits that are essential for life. The brain just doesn't have that capacity, Okay, but it will basically turn off things that you don't need, which usually is like, I don't care if you're awake or asleep. You don't need, that to be safe. So anyway, there's often a period of confusion, and this can last seconds, this can last minutes, and some of my patients that have lots of seizures, it can basically throw them off for the entire day. But something seems off. And then the last one, this is most vague, is that it may be not just seizures, but something else in their life has changed. So maybe their behavior, you've noticed a change when you're noticing funny spells, or their sleep has suddenly changed in some way. But just look see if there's other things. We heard that epilepsy is not in a silo. So start looking and seeing, hey, when these things started, this other things also started showing up. All right, we use EEGs, we use MRIs. Any patient who has epilepsy diagnosis needs both, okay? And you heard Dr. Mirza, and I totally ascribe to this thing too. Any patient with intellectual disabilities deserves at least one MRI, okay? We should try to figure out if there's more that we're dealing with here that we know about, or if there's anything to be gained in how we might approach the problem. Any patient who has a seizure deserves an EEG. I've adopted the TSC surveillance protocol, which is all of my patients, they always get at least a baseline EEG. And then if they're having spells that I'm not certain about, then we will repeat it. We may even do an overnight EEG to get a total picture of what their sleep patterns look like at night, as well as their daytime patterns. And we will repeat these not at a scheduled frequency, just when we're kind of needing to answer questions like, are they having seizures or not? Do we start medicine or not? Do we change medicine or not? Do we come off medicine or not? That's when we repeat them. The other thing is that you guys have half of an EEG in your hands 24/7. And even yesterday when I met with families, those that had videos of what their child was doing, this is revolutionary things. Always take care of your child first. So if there's only one of you, the video is not important, okay? But if you have a partner, a spouse, or if your child is in a safe place and you can get a video of it, that's very helpful to us to really help sort things out as well. We do not yet have information that says use this drug to treat epilepsy and Smith-Kingsmore. We use them all. Okay, but we try to use them strategically. We use medicines that attack different ways that neurons know how use to talk to each other, and we even use some medications that aren't directly involved in how they talk to each other. But we try not to just totally only hone in on one specific pathway or neurotransmitter mechanism in the brain. If we have to go to 2 medicines or 3 medicines, we try to be really strategic and combine them that can attack the problem from different trajectories. Okay. I will tell you that none of my seizure medicines have 0 side effects, okay? So that just comes with the territory. Now, the neurologist is trying to be very judicious in how to use these strategically so that we minimize those side effects. And also, what we're trying to do is have enough medication effects so that the irritated part of the brain can be quieted, but not quiet the entire brain that your child sleeps 24 hours a day, okay? Now, just getting back to this, and kind of my last section I want to talk about is where does rapamycin or sirolimus fit into this? And it's because we've been developing these drugs and treating things, including epilepsy and tuberous sclerosis now. We started our first patient on this drug in 2003. Our first epilepsy trial started in 2010. And we got FDA approval to use everolimus in the treatment of epilepsy and tuberous sclerosis in 2017. Okay. So this was the study that convinced the FDA that this could work for this. Now, I want to tell you, sirolimus or rapamycin does not treat epilepsy directly. Unlike all the other seizure medicines, although it's approved as a seizure medicine, in tuberous sclerosis, we are treating tuberous sclerosis. And then we are asking the brain to, either fix itself or start to change its dynamics in a way that will benefit in ways we do it. We showed that this can shrink tumors. Now in Smith-Kingsmore, at least to date, we're not terribly worried about tumors as part of the phenotype. In tuberous sclerosis, that's what happens with them. But from that, then we started seeing epilepsy benefits and treating epilepsy. And so, and this is a graph where you see at the very start of it there, where all the patients started at the same point. We counted their seizures, and then one group of patients got a placebo or had 0 active ingredient. One group of patients got a low dose target, and then one group of patients got a high dose target. And the high dose target is in the red, the low dose target is in the blue, and the placebo group is in the black. Now, what we see in any clinical trial, even with placebo, people get better. If you go see the doctor more often, you get better, okay? A little bit, okay? With the low dose, we saw a partial effect, and with the high dose, saw a high effect. But you heard from Dr. Prada, maybe for Smith-Kingsmore, high dose isn't the way to go, okay? Because we certainly can unmask other problems. But the other message from this is that it took time. We weren't blocking one neuron from talking to the next neuron like a seizure drug where you hope to see a difference within days or at least weeks. This was, we were actually going after the disorder itself, and that took time, okay? And in fact, I don't have here because of time, but we follow these patients out and we continue to get more responders even out to as far as 2 years, okay? Okay. Now, what's been done so far? Well, there is a case report of a patient who was treated with everolimus. Now, everolimus and sirolimus are, for all practical purposes, the same. Sirolimus is older. Sirolimus is cheaper, easier to get. It comes in a liquid, so it's easy to dose too. But it's, ampicillin, amoxicillin, penicillin. Think of everolimus and sirolimus in the same way. And so, basically they showed here that there, seizures went up and down, but for this at least one patient, it wasn't the differences they were hoping for. But as you heard, we do know that some Smith-Kingsmore patients have been treated with sirolimus or currently on sirolimus. So have we learned anything from those 7 patients? And this is where your surveys and your feedback come into play. So of the 7, we have data for 6, and this is what Lindsay Aubacher-Smith put together for us. And we learned after Jack's experience to not try to be super aggressive with the dosing. And there were a lot of improvements that parents reported. Now, this is not a clinical trial, so this does not have the scientific weight that's necessary, but this is what we say, we should get that weight and get the permission from ethics boards to let us do this. Some parents reported anecdotally that there was improved verbiage skills, decreased aggression, improved intention, improved hyperphagia, improved mood. Now, only one of these patients actually was having seizures when they started rapamycin, and the seizures went down, okay? But like I said, we have to be really cognizant that all of our medicines have side effects, and there was some effects on sleep rhythms in 4 of those 6 patients. So this is where we are moving forward for the next step, and I'm happy to talk about that either in questions now or questions later. But the take-home messages is that we are part of a family, and we can learn from all those other experiences, including all the experience that I and others have contributed in tuberous sclerosis. We know seizures are common in Smith-Kingsmore, but they're not a universal feature, and there is a lot of variability in what that seizure story will be for each patient, okay? And we do not have standardized surveillance and treatment practices, but like I said, I'm a strong advocate that every child should have an MRI, every child should have an EEG, and we can draw on the experience of these related disorders in our selection of traditional seizure medicines and treatment strategies, as well as development of novel ones such as rapamycin. Thank you.
Thank you so much, Dr. Krueger. Questions? Oh, you've got a microphone right behind you.
My question is, when we saw you in Cincinnati, we decided not to give Shiloh a chance at rapamycin because of his aggression at the time. Excuse me. Since then, he has had a VNS. He's also on 3 seizure medications, also deals with lots of sleep issues. How do you balance the concerns over lessening already problematic sleep versus possibly helping with seizures?
Certainly, on a case-by-case basis, okay? And also, we do anticipate within the next 6 months of having a mechanism to experimentally see what this can do for patients that builds on the clinical need sort of there. So we've outlined that strategy yesterday to do that. It's never easy, and it's not something that each parent and or clinician involved in that patient's care is going to be, universally in agreement on. Some people say, yeah, we definitely should try it because of where we've been. And there's going to be others say, we just don't know so much that I'm not comfortable doing this. So the answer is we have to balance it. There is no universal answer. It's the whole reason why we want research protocols for 2 reasons. One is so that we get the right data that can inform the next step in the process. The other reason to do that is that it's a very transparent and open, what we call an informed consent process, where the parent said, where we have explained, this is what we are proposing, this is why we think it's a good idea, this is the things why you might say no. And then the parent has the opportunity to say, I hear you, I totally understand it, and I want to do it. Or I hear you, I totally understand it, and we're not ready. And that happens all the time in all my clinical trials, including my TSC trials. So I think it's a good question, but that's how we approach it.
And just for reference, when we talk about the meeting yesterday, we got together all of the speakers that we have here, and we put them in a room for 2 hours and said, these are the things that we're really worried about. What should we work on? So this is one of the things. What we have to work on is how we raise money for it and pay for it and get the right people involved. But we're referring a lot to the meeting. It wasn't a secret meeting, just a meeting with all the scientists to try and get them aligned behind these really important things for our community. Questions? Any other questions?
So my son,
It's working. I can hear you.
My son had seizures up until the age of like 3 to 4, and we tried a variety of medicines. He's still on seizure medicines, but he has not had an active seizure, detected seizure, since 2019. After we did a pulse steroid treatment, but I haven't heard of that being like a point of discussion for any other patients. Can you inform me as to like why that's not discussed more? We had also discussed IVIG as well if the seizure or the steroids weren't effective.
So the basis of that comes from decades of understanding that in a patient with epilepsy, particularly uncontrolled epilepsy, the immune system and inflammation somehow play a role in that. Again, when I talk about these mechanisms of epilepsy, that's one of those where we know there, but we haven't figured out a way that it definitely does or doesn't play a role in each individual, and we haven't figured out by targeting it how much it's going to help somebody's overall epilepsy. We certainly, in patients with really refractory epilepsy, use steroids. We also use steroids to treat a particular type of epilepsy that happens in infants called infantile spasms. And the idea that steroids either works as an anti-inflammatory strategy or that it is there's a lot of responsive genes to steroid signals, and so it may also promote certain gene expression patterns that favor a resolution of somebody's epilepsy. The reason why it's not universally adopted is because in comparison to many of our seizure drugs, steroids have immense side effects with blood pressure, with behavior, with sleep, and overall metabolism, including difficulty regulating sugars and things like that. So we use them very judiciously because of that. We use them very short term. Conditions that require chronic steroids means that your child has a lot of other medical issues just because they're on that treatment. So we can use it. We use it judiciously as neurologists in very select situations, but it's not a universal treatment because of all those complexities.
Thank you. My question is just, how would you characterize the relationship between sleep issues with SKS and seizures and just neurological factors? In our case, our daughter used to wake up at like 2 a.m. every single night, not go back to sleep for, I don't know, it at least seems like a year. Maybe it was less than that. Then we started her on, it was a year and a half. Then we started her on valproic acid, which has controlled the seizures since then, and her sleep also just magically got better. So is the hypothesis that that's like the main cause, or what? Yeah.
The hypothesis is it is literally a chicken and egg problem, okay? We do know that patients who have a disrupted sleep are more prone to having seizures, period. If the brain does not get restorative cycling through the night, then they are more prone to having seizures. And what we don't know is how much it is that you don't get good sleep and that causes you to have worse seizures, which then affects your sleep and whatever, or you have seizures and that's affecting your sleep, and then it just kind of cycles back and forth. We also know that our brainwave patterns change as we sleep. And so I like to think of it as we have one physical brain, but we have two functional brains. One's the sleeping brain and one's the awake brain. And something we've observed for decades now is that when a patient is transitioning from their sleep patterns to their awake patterns on brainwaves, or when they're vice versa, certain patients, that transition is what wakes up faulty circuits. So we see that phenomenon as well. And we know patients who don't get good sleep, we've known that for decades, that they're more prone to having seizures in the daytime as well. When I hear that relationship and I don't know which of these is at play, my first step is usually to get an EEG during the night, okay, and see if there's evidence of any epileptiform activity that may be contributing to their waking. The second thing is I try to get very aggressive with their seizure medicines, particularly with their nighttime dosing, in case that can solve the problem. Because even if I can't tell you which is the chicken and which is the egg, if I can break the cycle, I can be successful. So that's the best way I can answer that. And it doesn't always work like you guys had, but it does work enough that that is a very valid way for a start, because that's a treatable problem. After that, then we just start working on sleep and seizures, possibly as two separate issues, but knowing that they somehow are linked.
Thank you so much. We are going to push our break out by